everyone, this is Amanda Moore from the Angelman Syndrome Foundation, and you're listening to the ASF podcast, the show that explains everything you want to know about Angelman syndrome. We're so excited you're here, and we hope you enjoy the show. Hey, Amanda Moore here from the Angelman Syndrome Foundation. For this week's podcast, we have repurposed a webinar that was recorded in years past, but the information is still very much relevant today. We hope this information helps you on your journey. Enjoy the listen.
Welcome to our next session. This is a Ask All, Tell All session with the illustrious group of clinicians that I have up here. I have from my side across the table, Dr. Jessica Dewis, who is a geneticist at Colorado Children's. I have Dr. Thiebert, who is a child neurologist at Mass General Hospital. I have Dr. Elizabeth Berry Kravis, who is a child neurologist at Rush. And then I have Dr. Mark Nesveka, who is a child neurologist at Rady Children's Hospital. This is, like I said, this is your opportunity to ask any question that you'd like to. I will make a note that there's a all things seizures session later in the day. So if we get real nitty gritty into the seizures, I might deflect some of those questions later into the afternoon panel, as well as diet. There's a diet session following lunch. And so we can certainly do 30,000 foot view questions on those issues, because I know that they're really pressing and important. And if folks are missing the afternoon sessions, but I just want to highlight that there's completely dedicated sessions to diet and seizures and epilepsy later in the day. To start us off here, I see that we have at least a handful, if not more, newly diagnosed families in the room. So I just want us to level set kind of first on what the common medical issues are that we see in children with Angelman syndrome. And then we'll kind of go into school age, adolescence, and then adulthood, and how these medical issues change over the lifespan. So Jessica, Dr. Dewis, I would like to start with you. If you're seeing a newly diagnosed family, because I know this is a lot of what you do, what are you going over with the family in that first visit is kind of the common medical issues that you're seeing in kids with Angelman syndrome?
Yeah, so if you're new to the clinic and just coming with a new diagnosis, we'll often first just take a minute and talk through the genetic information. We do take some time also to talk about the psychosocial aspect and making sure that you have a tribe, both connecting you to the Angelman Syndrome Foundation community, to the social media community. And really, that is huge for families to have that opportunity to engage with other families who have been through the same thing. I try to keep it kind of light, and I don't go into too many details, but really focus on the child. Some of the things that I always ask about and think about would be how feeding is going, how growth and development are going so far. So we'll look at the growth curves. We'll talk about what the child's eating, how they're feeding, if there's any concerns about choking, keeping things in the mouth, and really focus on that. Oftentimes when they first come in, if they're younger, they're not having seizures yet, but we'll talk about the possibility of seizures, preventive measures for seizures. And then we often spend a lot of time talking about sleep, which might also be an issue, and talk about ways of behaviorally managing sleep and creating good sleep habits. And then constipation and GI issues are things that come up and very early on. And so we'll often spend some time talking through some of those and how to treat those. And then there's something big I'm forgetting. But it's really psychosocial. Like, we really want to make sure that you feel supported, that you have that tribe, and that you know how to get in touch with us if you have questions or concerns. So we really make it clear that the visit doesn't start and end with when you're in clinic, but that it's a relationship that you can get in touch with us anytime if you have questions or things that come up.
Awesome. Thank you. I think you hit on all the big areas in early childhood. Dr. Thiebert, I'm going to pass it down to you. As we think about kids evolving into school age and even early adolescence, how do some of these medical issues change, and what are the things that are more pressing then?
Oh, yeah, that's a good question. So, the concerns for, 3 and 4-year-olds are different from 9 and 10-year-olds, are different from 17-year-olds. Anytime after, 2 to 3, that's often when seizures can present. So, as kids get older, there's more of a risk of having seizures. But then as they get closer to puberty, they often kind of get better on their own. Not always, but in a lot of kids, they tend to just kind of start to just be a little bit easier to treat as they get older. And even just kind of thinking about seizures in general, like some kids may have a couple and some might have lots. So it's really kind of a spectrum. Just because some kids have tons of seizures doesn't mean everyone does. Some will only have a few or maybe none. But as you get closer to puberty, the seizures tend to get better. Sleep often gets a little bit better. But what we see worsen is anxiety once puberty hits. And I mean, that's in any kid, Angelman, no Angelman, but, it presents a little bit different, obviously, in kids with Angelman. So that's one big thing to watch is the anxiety. And then they can also get, what we're seeing a lot more of now is that this kind of a part of the movement disorder, the non-epileptic myoclonus, where they can just get real twitchy. And for a lot of people, it's super mild and is never a problem. For some, it can be pretty disruptive. It can last a long time and really kind of get in the way of things. So, but that tends to be what we see is seizures and sleep getting somewhat better, and then anxiety and myoclonus often getting worse. And then GI is kind of always there. It doesn't, for some kids, it's a big issue. For some kids, it's not. And it just, it's kind of always on the table.
Great. Thank you. All right. Dr. Bray-Kravis and Dr. Nespeka, who wants to tackle adulthood? What are these major issues you're seeing in adulthood?
Well, we have been seeing a lot of adults in our clinic. I think there's a huge need there because people kind of fall off a cliff when they leave school and there's no support services and so forth. So things we go over with adults are, where are they living? What kind of services do they have? Do they have anything? And then kind of seizures, behavior, and sleep are kind of the 3 major categories of things that may or may not still be going on. Sometimes I find that patients who've been living in a group setting come in because of loss of skills, and there can be motor deterioration and gait changes as the patients get older. But sometimes they're just having episodes of twitchiness or non-epileptic myoclonus, and whoever's taking care of them is just raising their dose of benzodiazepines every time they have an episode. And so I have seen patients who've actually lost the ability to walk or perform things just because of being overdosed on medication. So often a medication review for the adults that have been, in a group home and managed sometimes by a psychiatrist, sometimes by an adult neurologist is really always indicated to make sure that we're not running into complications even of medication use.
Great. Yeah, anybody can add.
So I really don't have much to add, especially since our clinic does not see many adults. The main adults that we have seen at Children's are people that I've often followed for many years, who are local folks who get into their early 20s and so forth. So I would certainly defer that. Maybe we should have had Ron sit at this end of the table.
Every question can be answered by everybody.
So,
Dr. Dewis, you have something to add?
The big thing that I was forgetting, which shame on you all for not identifying, just joking, is early intervention is so key in making sure that families are connected for services early on. That can have a tremendous benefit.
Awesome. All right. So let's dive in deeper into some of these issues. We know that GI issues are really pervasive in Angelman syndrome. And it sounds like across the lifespan. While they might change at different periods of life, they're a persistent issue. So the main issues that we think about when we're thinking about GI are constipation, reflux, and gagging, vomiting, those sort of things. So Dr. Dewis, talk us through kind of some of your recommendations and what you're seeing in the clinic.
Absolutely. the biggest thing that we see is definitely constipation. And I will say sometimes constipation comes in as increased seizure activity, more problems with sleep, more behavior problems. So definitely always having constipation on your differential when you're thinking about anything with Angelman syndrome is important. And we even often find that kids, families don't even recognize that there's constipation and will get just a abdominal film to look because we don't understand what's going on with changing behavior, and we'll find that kids are pretty backed up. So what we recommend is something every day, even a low dose of something to try to prevent the constipation. Magnesium is something that we'll often try first because it's something that naturally is in the diet anyway and can be really helpful. So there's a product that I really like called Oxy Powder. That's something that you can open up a capsule, for example, and just put it in any food. And that can be really helpful. Reflux is something also that you really need to think about when kids come in, particularly with sleep concerns, new onset of sleep concerns, arching, and should also be considered for treatment, particularly when kids are pretty young. And depending on the severity of it, we might start a shorter acting agent versus a longer acting proton pump inhibitor, but there's many things out there for reflux. And then the other thing that we're seeing a lot of, which I'd be interested to hear what everybody else thinks about, is cyclic vomiting. So we're often seeing, particularly if the gagging starts, which can be triggered by many different things. For example, anxiety can even trigger gagging, that it can start the process of cyclic vomiting, which can be pretty debilitating, and kids can need to go in and have fluids. So we are using a lot of headache treatments for that, for chronic headaches. And those have been somewhat successful for the cyclic vomiting, in addition to abortive agents. So things like Zofran, which is a medication to make you feel less nauseous when the vomiting starts.
Yeah, I don't have too much to add. One of the things with you're talking about constipation, I think Jessica made a great point that a lot of families don't know it's happening, because what happens a lot of times is you'll have a kid that poops every day, but if they're only kind of pooping out 60% of what they should, then it gets kind of backed up. So even if it's coming out every day, it doesn't mean that it's not kind of backing up. And at some point it can even get looser because it's kind of coming around the backup. So, it can be where, the story is that there's bowel movements every day and they're getting a little bit looser. It doesn't sound like constipation, but it can be. And that's where, that's really have to kind of dig into the history and kind of find out how much is coming out. And then the cyclic vomiting is, that's definitely something that we see a lot. We tend to see it more in the adolescents and adults, but sometimes we see it in kids. And it's interesting, for some kids, there's a big anxiety component, and it's really just treating the anxiety really kind of stops them. But for others, it really is, almost like a migraine variant kind of thing. And we use the medicines that Jessica was saying, like Topamax, Periact, and those kind of medicines that we use to treat migraines. So that's a little bit tricky, but there's always an anxiety component to it. So we'll often do a little bit of Ativan if it starts, but those medicines that we use for headaches can really help prevent those. And then the other big thing we see is reflux, and that can, so when kids are refluxing, they can actually eat more to treat it. So if you see appetite increase for no clear reason, sometimes that's reflux. Other little clues for that are like waking up, coughing at night, because kind of reflux when you're laying down. So you don't always have to like spit up or even burp a lot for reflux. Sometimes the only clues you have are just increased eating, and then sometimes waking up in sleep. But yeah, there's we're always, anytime anything worsens, seizures worsen, sleep worsens, that's our first question, like how's GI going? Well, first question is how's sleep going? Second question is how's GI going?
Yeah, I don't have a huge amount to add to that, except for I do think reflux can be quite under-recognized, and it can manifest as things that don't look like reflux, like behavior. And we have that not only in Angelman syndrome, but in Fragile X and other conditions. And so I think it is really important to have a bowel plan if you have any kind of problems with constipation. And sometimes there's really just a need to look and see whether to do a good workup and look and see whether reflux is present. And we have a very good GI doctor who's a med peds person, so he sees both kids and adults. And he does a lot of endoscopies for us. And we found some people with Barrett's esophagus, which is a really kind of damaged esophagus from so much reflux, just because it hasn't been kind of looked for because it hides under other symptoms. So that's probably all I have to add.
Yeah, I would endorse what Elizabeth just said, and what a colleague of Ron, Margaret Bauman, who specializes primarily in autism. She came to our institution once several years ago and showed everybody in the neurology department a whole bunch of episodes of adolescent and young adult and even some school age kids who were having these bizarre spells. And most of us thought, oh, that's a seizure. And it turned out that each and every one of these kids had really horrible esophagitis, and all of their symptoms went away when that was treated adequately. So I think we as clinicians always need to be thinking about what it is that looks like a seizure but isn't really a seizure. The other thing I've just recently seen in the last few years is the cyclic vomiting thing. That hadn't been something I'd had much experience with. And I just wanted to share that my favorite anti-migraine treatment, riboflavin, did not work in any of the 3 patients I used it in to try to reduce their cyclic vomiting. In California, it's much easier to get families to use a vitamin than a drug. But this didn't work. Maybe we need to have 4 patients treated with it to find one that it works with. So
this brings me to my next question. So is there an age at which you see reflux kind of peak, or do you find this to be a problem across the lifespan in Angelman syndrome? Anybody?
I think it's across the lifespan.
Okay.
And I think sometimes it's in kids, they're kind of irping stuff up. I think it hides more in the older kids and the adults. So you don't realize it's reflux. It presents as something like what Mark talked about, or just as behavioral outbursts because there's pain and the reaction is to have behavior.
Do you feel like we need to consider recommending upper endoscopy, things like that, to rule this out, or do you just do a trial of medication and see if some of these things get better?
Yeah, we should do the trial of medicine. The medicines are so benign. It's one of those things where you treat it, and if it gets better, you know what it was. It's a 2-for-1. You're treating it and diagnosing it. Unless it's, and if those medicines don't work and it's really severe, then you end up going towards endoscopy. But if we can, save these kids' procedures by just treating it makes a difference.
What medications do you find most beneficial for reflux?
The ones that work best are the PPIs like Prevacid and Prilosec and those kind of things. The older ones, like the Pepsids, those are a little bit safer. So if we can get away with those, we do. But sometimes people just need to be on the stronger ones. And it's kind of like seizure medicines. You don't have to be on them forever. Sometimes we'll put people on them after a good run of no symptoms. We try coming off, see if the symptoms stay gone, and sometimes they do. So even if you start reflux treatment, you're not kind of married to it for forever.
What about diet? Is there a role for diet in the management of reflux?
Definitely. So, there's definitely, certain foods that can kind of worsen that. Even just being on like our really healthy diets, like the low glycemic, the low glycemic, the ketogenic, it'll worsen reflux because there's so much fat. But then there's foods that are really good on the diet, but can help kind of move things along, like coconut oil and avocado. And we can always bring Heidi up to talk more. But even before, like for constipation, even before you add a daily medicine, if you can get away with just adding some oils to the diet and changing that around a little bit, fruit juices, that kind of thing, you can sometimes make things better before moving to like a Senna or Miralax. But for a lot of kids, the constipation is just too much, and that isn't quite enough. But sometimes it works.
The one thing I would add to that is that we are seeing a lot of kids are recognizing the prevalence of things like eosinophilic esophagitis in kids with Angelman. And so even that can present with reflux as well. That's often refractory to treatment. So I'll often try a treatment first, but definitely I think we under recognize the role of endoscopy because eosinophilic esophagitis is often treated with an elimination diet. So figuring out what could be causing that reaction, and as well as there are certain anti-allergy type of medications that can be really helpful and treat reflux in that context. So I do emphasize that, going to endoscopy is something we do try to avoid a lot of times, but it can be really helpful and kind of change the trajectory of treatment.
Cool. Anything else to add there?
For those of you who don't go to a major medical center that has specialist gastroenterologists who will listen to their neurology colleagues, you may need to plant the seeds in your provider to beg for a gastroenterology consult, specifically with a gastroenterologist who's open-minded enough to think that that bad reflux, esophagitis, eosinophilic esophagitis can result in non-typical gastrointestinal manifestations. Mm-hmm. And then you have to often argue to request for endoscopy. So, and that's really necessary to really diagnose that in many circumstances. So,
and I'll let Jessica put in a plug for the standard of care paper that you can now get to your primary care provider or your GI doctor who may not be listening. You want to tell, I don't know, the crowd.
Yeah, absolutely. About that. So I don't even remember when it was published because it took so long, but recently there was a paper that was published that was a consensus of national and international working groups in terms of every aspect, where we tried to include every aspect of Angelman syndrome. And, also we have a resource available that's an emergency hotline, as well as additional resources and an email available. And one of the things that has really facilitated is getting medical literature to providers who may not want to talk to us, but at least if there's something on paper, it can give them a pathway of how to think about some of these medical issues. And that was published open access, so anybody can get a copy of that. There's also a ton of supplemental material that you can share with your therapist. So there's pathways for thinking about sensory issues, pathways for thinking about AAC within that paper as well, that I think could really help facilitate at least discussions with your providers about these unique aspects of Angelman and how to treat them the best.
Yeah, Dr. Dewis just alluded to how long it took to get that piece of literature out into the world. It was largely spearheaded by Dr. Dewis, contributed by all the folks on this stage and clinicians from around the world. But this is really a fabulous, powerful tool that you can have. I mean, I'd encourage everybody to download it, have it on your phone, be ready to give it to a provider who might, just need that little extra nudge to say, yes, this is really an issue in Angelman syndrome, and here's ways to think about it. So it's a really phenomenal resource. And then if they're willing to reach out provider to provider to the hotline, then they can, chat with a provider who really does have expertise in Angelman syndrome. So really great resources for the community.
So one phrase, if you happen to reprint the paper that Jessica authored, as you give it to your clinician, is to just say, can I count on you to be helpful in this, and read these paragraphs?
Yeah, highlight them. This is an issue.
That might work.
We know this is a problem. Okay, any parting thoughts about GI issues? I think.
I have one thought. So my favorite for patients who are not on low glycemic or ketogenic diet is prunes. Mm-hmm. And I've had several patients who tell me prunes work better than Glycolax or Miralax. Mm-hmm. So it's worth trying, but not worth trying if you're trying to stay ketonic. So.
Go. Yeah.
I would just emphasize what I think all of us have said is that don't underestimate the power of these GI concerns in impacting other aspects of your child or adult's life. We certainly see kids come in where families think it's seizures, family thinks, there's some change in behavior at school even, and it's really related to these GI concerns, which, as Dr. Baird Kravis said, can cause pain, discomfort that we're not really recognizing as such. So just always keep GI on your mind and be thinking about that when you're talking with your doctors.
Anish, go ahead.
And even if it is kind of building on that, even if it is something that is there like they are seizing more, there is bad sleep. You always have to think about GI. Is that the trigger? Is that why good seizure control all of a sudden became not so good? If there's no other clear factors, because we have seen seizures really spike with bad constipation. Definitely myoclonus can get so much worse when kids are constipated.
Okay.
Yeah, non-epileptic myoclonus in the adults, when they're constipated, it can just go crazy.
Okay, so we always recommend, we say, for folks who are on diet, either LGIT or keto, to add oils, that oils can be so beneficial. But I feel like sometimes parents look at me like I've got three heads. Like, how do you want me to feed my child or adult oils? So how do you counsel families to get oils in?
So when we talk about diet, we always talk about balanced meals. So we're always talking about if you're doing a low glycemic index therapy, we try not to be super restrictive. But when a family wants to give something that's a higher glycemic index food, like bananas come up frequently, we say, give a smaller portion of a banana, but then also balance it really nicely with a protein and a fat. And the oils can certainly serve that role of a fat. So we often recommend medium chain triglyceride oil, because it's pretty easy to digest because of the way that it's digested. And it can really help facilitate the goals of those types of diets, which I know Heidi is going to talk more about, but can really help us facilitate kind of switching over metabolism to use fats instead of sugar for energy, which does seem to have some benefits that are mostly published in the medical literature for seizures, but may have other benefits for Angelman syndrome. So particularly for families who want to go in that direction, starting with oils can be a good way to do that. The other thing that we find that oils are really helpful for is actually treating constipation, because they provide also a little bit of gut stimulation. And so that's something that, especially in kids who are thinking about low glycemic index therapy, but also have a little constipation, we'll think about oils from that perspective too.
But you have young children. How are you physically getting it into them? Are you putting it in a syringe and they're taking it? Or are they putting it in a sippy cup? How are you doing this?
We always add it to something. So we try not to add it to dairy products, but you can add it to yogurt even though that's a dairy product, but or applesauce, or some families put it in, if they'll take like a sippy cup, they'll put it in the first part of their sippy cup. The bottle before bed is one that families like and seems to work.
Cool. Awesome. I saw somebody who had taken an applesauce squeezer pouch, taken like one sip out of it and added some oil into it. Super effective.
Oh, yeah. No.
Okay, perfect. Okay. And at any point, seriously, folks, come on up to the microphone and start asking questions if you want to. We're just going to keep cruising through some common medical issues, taking a little deeper dive, but don't hesitate to jump in if you have questions. All right, we're going to go to seizures. Again, respecting that we're going to have a whole seizure session this afternoon, but we'll do a little 30,000-foot view teaser here. All right, so Dr. Thiebert, you're seeing a newly diagnosed family. We talk to a lot of newly diagnosed families. There's a lot of anxiety. If a child has not started having seizures, what do those first seizures look like? What are parents, what do they need to be looking out for? And what do they need to do if they're worried about it?
No, that's a great question. So, for newly diagnosed families, the first thing we talk about is that, the genetic subtype really depends. For kids with deletions, it's, 90% or more, usually more. But for kids with imprinting center defects, it could be 50% or less. So, and then the other types are kind of in the middle. So, it's really important to know kind of what type of Angelman syndrome that your child has, because that kind of makes a difference. And then we talk about when they typically start. They often start, like 2.5, 3 is a common age. They can be a little bit earlier, especially with fevers. They can be a little bit later, but the first seizures usually come with fever, not always, but that's often the first time you see seizures. There'll be a fever, they kind of pop up. And then, and they're often not the big kind of eyes rolled back, shaking kind of seizures that are really easy to spot. The first seizures are usually either like what we call absence, which is a kind of a staring spell, and those are often that I know those cause a lot of anxiety because all the little kids stare. So it's just for a few seconds. You snap your fingers, they turn around. That's not a seizure. These are what we call atypical absence, and they last 10, 20, 30 seconds, and usually come in clusters. There's also head drops. So they're just kind of quick head drop, little looking stunned for a second or two. Again, kids will do that when they're tired. So if it's only as they're falling asleep, that's normal. And then the other type we see is the myoclonic seizures, which it's kind of like the twitching we all have in sleep, but awake. But the best thing you can do is I know they're short, but if you can get a video of it, that's super helpful for us to really look and say, okay, that's seizure, that's not. The other thing that really helps differentiate, if seizures are starting is just how are they doing? Are they just really cruising along developmentally and everything's great? Or like over the last couple of weeks, have they not been doing this as well, not been doing that as well? If there's some kind of change in the level of how well they're doing things, that's more of a clue that there's seizures going on. And then we just kind of talk about the different treatments, which is a whole talk into itself, but like once they start, if they start, what's the first course? Is it medicine? Is it diet therapy? And so it's good to have kind of a plan in place ahead. So if they start, we kind of already gone over like what the options are and what are we gonna do.
We get this question a lot. Is there a need to do a baseline EEG before you're concerned about seizures?
That's a good question. So it was, is there a need for a baseline EEG? I usually get one, and it's just a routine, not an overnight. Like after the diagnosis, it's good to have the EEG, just to, like one, to make sure there's no seizure activity, but also just to get the baseline of the notch delta. There's an EEG finding that almost all kids with Angelman syndrome have, and some kids have more of it, some kids have less of it. So it's always good I always like to get that baseline when kids are doing well, and then that way, if things aren't going as well in the future, we get an EEG, we have something to compare it to. So not everybody agrees, but I like to get just a routine EEG as a baseline. I don't know if you guys do the same.
A lot of patients come to us having already had an EEG.
Yeah.
So often we don't have to get it when they come. If the kid is really young and not really at the age that patients have seizures yet, often I won't necessarily get it right away. Certainly if they have any evidence of anything during an episode of fever, then, we'll get an EEG at that point. But I usually don't start patients on medications preventatively at all. I wait until they start to have some kind of episodes. And then if they have, and it is often like a kid that's 2 or 3 and gets sick or gets a fever, and that's when they start having the staring and blinking and the drops. And then we'll usually start Keppra first. But again, the trajectory through anticonvulsants, I think most of us all use, the goal is to try to keep patients from getting on too many medications, like so many medications that their function is actually more inhibited by the medication than by the seizures. And so often we'll use these tapers, that patients take just when they're sick, and then they come off of it so that they can control the seizures when the seizures are worse, but not have to have the side effects of the medication in between seizures. But then the EEG I kind of get when I feel like it's going to be helpful in terms of management, or when the patient's in a clinical trial, because right now we're doing EEGs on everybody in a clinical trial.
I don't always recommend an EEG if a child comes with nothing suggestive of a seizure and a known molecular diagnosis, or if it's a child that somebody in our department has seen suspecting Angelman syndrome and genetic testing confirms that. But if there's something suggestive of seizures, then I'll usually get it. And many times we may have to do longer recording to capture the events in question to know. So, and when we started out doing the natural history study in the late 2000s, doing an EEG was part and parcel of the initial clinic visit. and so many parents complained about the process of getting 21 electrodes put on your scalp, that we stopped having that be a requirement. Right, Wenhan? Yeah. So doing an EEG is no fun, but oftentimes it can provide a lot of helpful information to us.
Yeah, the CAP has been a great advance in that regard. Yeah, and I just want to emphasize the value of videos, because often, the family is emailing you, he's doing this, what is it? And we try to have people just take a video of it, because that can be really helpful. Sometimes you can just look at it and say, okay, that's definitely not a seizure. And sometimes you can look at it and say, that's definitely a seizure. And then for the ones in between where you really don't know, that's where you're going to try to monitor it with an EEG.
Yeah, and there's one great point that I missed. For newly diagnosed kids, getting the screening EEG, I don't get them before age 2. The EEG changes a lot the first couple of years, and often that notch delta that we see doesn't show up until 2. So if it's like a 10-month-old, we won't get one right away. We wait till they're older. And then as far as preventive medicine, I think we all agree that we don't start medicines to try to prevent. You just kind of wait and see what happens. A lot of, as Heidi will tell you, we see a lot of new patients who already kind of been put on the low glycemic diet, just by the parents. So, that's one of the things that we see a lot. And that's actually not a bad thing to do for these young kids. Definitely, with a dietitian monitoring, but what we'll often do for especially the kids that have come in, they're already kind of on that diet. We'll have them continue taking kind of low glycemic foods, but not do a strict carb count. You don't need to really restrict carbohydrates if there's no seizures. But if young kids are kind of growing up just eating these kind of low glycemic healthy foods, it's easier to switch to a more strict diet as they get older if they need it for seizures. And what we also see is a lot of kids are eating the healthier diets. They're just more focused. You don't get those sugar rushes and the crashes. So that's one thing that sometimes we'll do pre-seizures, just because it's healthier and it can help other things. But again, not with a strict carb count, so we don't have to you don't have to worry about getting ketotic or anything. But I said a lot of families just show up on it already, and then we just kind of tweak it.
Anything to add, Dr. Dewis? I know your team uses diet pre-seizures often.
We do recommend getting on diet pretty early, and do feel like there's other benefits, perhaps for attention, as was already mentioned, but even other benefits. We're trying to more systematically study that, but it's very difficult. Lots of confounding variables to really have a clear data set to look at, but we do think we're seeing some benefits
From a seizure control standpoint.
for seizure control, but also potentially for development. And it's hard to say if it's, getting really early interventional therapy, lots of therapies, very proactive families, or if it's related also to the diet.
Yeah, great.
Hey guys, it's Amanda here. As you know, we're here for you, our community. If you have questions about any topics we can discuss in our podcast, or if you have ideas for future episodes, we'd love to hear from you. All you need to do is email me at dearamanda@angelman.org. Thank you so much for listening and your continued support of the Angelman Syndrome Foundation.
I have a question in the back.
Thank you so much for your time. I have 2 questions. First of all, earlier you mentioned about that publication as well as the hotline. Could you provide us with information on where to download the publication and what the hotline is? That would be great.
Yep.
Go ahead.
Yeah, absolutely. So the publication, the easiest way to find it is actually just to Google management Angelman syndrome, and it comes up pretty quickly, or you can do consensus statement Angelman and it will come up pretty quickly. And then you can download it from there. And there's no barrier to downloading it in terms of the journal because it's open access. We can also make sure that we put that out there and provide the link to everybody, put it on the Angelman syndrome website too. And then the hotline has a direct phone number. which I can give, but I can also make sure that this is out there. So 720-777-0015 is a number. But we also have an email address, Angelman Expert Consult at childrenscolorado.org. And we can put all this out there. There's also a 1-800 number. There's immediate access to an interpreter if you need one. So if you're calling internationally any time of day, you can get through to the line, and where that is really geared towards provider to provider consultation. So if someone's in the emergency room or a provider in the community has questions about how to manage sleep, behavior, any aspect of Angelman, we're more than happy to help in real time with that provider to provider consultation.
Okay. My second question is that my daughter, she has 2 benign arachnoid cysts in her brain. We were told by her doctor that those are no problem. You just need to monitor that. Is that, just want to bring that up and ask for your opinions. Is that, is it true that we just have to monitor from time to time?
They're arachnoid cysts?
Yes, two
Yeah.
benign arachnoid
Yeah.
cysts. in her
Those
brain.
are usually just congenital, minor, and especially if they're small, we don't do repeat MRIs and monitor them usually at our site.
Okay, thank you.
Great. I will add the consensus statement. The management guidelines can be found on angelman.org under medical resources. So on the foundation website, you can go there and find a link to it as well.
Y'all may have covered this and I missed it, but I have a 19-year-old deletion plus, and a pattern that I feel like I've seen with him is that when he is on antibiotics, he thrives. Sleep improves, his behaviors improve. I just see across the board, I feel like an improvement. Is that something y'all have seen, experienced, or have anything to say about?
I think the question was, when your angel is on antibiotics, he does what? Better. Sometimes that's related to GI symptoms, and some antibiotics can actually help treat GI symptoms, so can help prevent constipation, but also provide some stimulation to the gut movement. So if there's reflux or what we call dysmotility, where things are just not moving through, the antibiotics can really help with that. So I would wonder if that's related to GI symptoms that actually are treated and get better when you are on an antibiotics. We do have a few kids that we follow where GI has thought about small bowel overgrowth. So they will put kids on antibiotics for a period of time every month or every few months. So that's something to think about too.
Oh, if your child is getting antibiotics frequently throughout the year for either known or strongly suspected bacterial infections, it may be worth trying to get an evaluation by an immunologist to make sure there's no incidental immune deficiency. So
the one other thing I'll mention is that we have some children and adults with Angelman that we follow that have some aspiration all the time. And so even if it's silent aspiration, so we don't know that it's happening, and then going on antibiotics can help treat that, and they might feel better. And so some of the symptoms might resolve when they're on antibiotics. So thinking about swallow and dysphagia, or abnormalities in how they swallow, can also be really helpful.
Great. Leslie.
I just had a quick question about adult angels and the clinical network. So would you advise that my sister's 34 and by all accounts healthy, knock on wood. Her seizures have been under control for many years, but with the expansion of the clinical network, would it be beneficial to connect with one of the clinics closest to us to create a baseline? And if so, what would you recommend being the standard tests or things that we should do to connect her now before we have an emergency situation?
I definitely think it would be beneficial, not necessarily for getting an EEG or any specific evaluations. But just to have a clinical team that knows Angelman, looking at your Angel, there's a lot of things that we see get worse in adulthood or change over time, like non-epileptic myoclonus. Thinking about some of the GI symptoms we've been talking about and how those come up in adulthood, sleep concerns. And then the other reason I think it's helpful is that we are doing a lot of work within the clinical network trying to understand how mobility changes over time. We're definitely seeing some changes that we are calling a flex knee gait pattern, where ultimately there's some flexion contractures that happen in the knees and the hips, and really thinking about how to treat that and prevent it. And so those types of issues that come up where there's access to the network, I think are really beneficial for adults.
Yeah, no, absolutely. And I think, a couple of things. One is, even if people seem like they're doing phenomenal, and they could maybe even do a little better if there's certain things that are really subtle and not being missed. And then the other big thing I think with adults is exactly what Liz said before. We'll see a new adult with Angelman, and they'll be on a bunch of medicines. And first thing we say is like, well, why is he on this medicine? And like, it's just been there for 20 years. So we left it. So there's often a lot of medicine, so that's the big thing. You go down the list and it's like, do you need this? Do you need this? And we can often just get rid of some medicines that are just, it's kind of like we started it, things got better and we just left it. But if that's been there for 20 years, do you still need it? Especially if and sometimes just taking those away takes away side effects you don't know are there. And it's like, oh, hey, look at that. They're doing this better, that better. So that's a big thing, just reviewing the med list and getting rid of what you don't need.
Yeah, I think there's a lot of adults who are on multiple anticonvulsants just because they have Angelman syndrome, and they come to clinic and they haven't had a seizure in 15, 20 years. And, you want to be cautious because there is potentially propensity for the seizures to reappear, but you can kind of gradually start weaning them off of some of that. And the patient may actually become more functional. So that's a really important point, is just having a med evaluation if they're on a lot of medications.
I would underscore what Liz said about being on a lot of medications. If your Angel is a young adult and taking a small dose of clonazepam or clobazam or something like that, then it's worth discussing with your neurologist or with one of the neurologists at an Angelman center, whether it's worthwhile continuing. And there are pros and cons to each of those choices. So
Thank you.
And the benzos are usually like we've seen over the years, angels who have been on a tiny dose of something for years often don't like it when you take it away. We had one, a 30-year-old woman who had been on 1/8 of a milligram of Klonopin, and we took it away and she just went off the rails. So we added it back. And the psychiatrist that was seeing her with me, I was like, yeah, just put the 1/8 of a milligram back. And he's looking at me, he's like, come on, like that's ridiculous. But it's true. Like once their brains get used to it, it's hard to get rid of it. But so a lot of times that little dose just kind of needs to stay there. But, we often see people that are on like ethosuximide and like a bunch of older seizure meds that they started back in the, in the 80s or 90s, and they just don't need it anymore. And it's just makes life easier to get rid of those meds.
Great. Next question. Thank you for your work in this area. My son is 27. And he has a lot of the GI issues that you've talked about, and they seem to be getting worse, from eosinophilic esophagitis to reflux. He's also gotten through a sleep study and had over 60 episodes within an hour. At first, he's kept his CPAP on. Now he will not. One of the things we're starting to see more of, and I don't really have anybody that's following him with, is twice we've done blood draws for other things and found that he's dangerously low in iron. Would they be related at all? And he has severe reflux. And so would they be related? What are some of the things we should look at and help him with?
I'm not sure I heard the entire question.
I think the
We still have it.
question was, her son has been found to have really low iron. Question whether that is associated with increased events on a sleep study, and whether that would be related to bad reflux.
So absolutely, there's more and more data coming out, both in typically developing individuals and in neurodevelopmental disabilities that show that low iron definitely contributes to events on sleep studies. In particular, they tend to be restless events, but we have started really trying to keep the iron level, trying to manage also constipation, putting kids on iron, but above the level of 50, just because we do see that that really helps the sleep events at night. It sounds like the events you described are like, were they felt to be associated with obstruction or just lots of movement at night? So it'd be helpful to have some more information about the specifics of the sleep study. Sometimes there are surgical procedures that can help with both the reflux and also the nighttime awakenings. Reflux also causes a lot of nighttime awakenings and can be a cause for sleep issues as well.
Right. So he's got severe reflux, eosinophilic esophagitis, and he's been on medication since he was about 12 for those things. The sleep study he was stopped breathing, or they weren't just awakening events, they were serious events for the sleep study. But twice we have found that he's also extremely low with iron, but that's not something we were looking at. They happened to find it. And I'm wondering if some of those things are related.
I think they are all related to each other. So I think correcting the iron would be really helpful, but you got to monitor too for constipation, which can make reflux worse. So you can get stuck in a cycle. But I think all of the things that you're describing are probably interrelated to each other.
Can I add that iron deficiency treatment with supplemental oral iron or therapeutic oral iron can really be vexing because it produces constipation and can make certain things worse, as Jessica mentioned. There's one patient I have with another neurodevelopmental disability who had very, very significant iron deficiency, and we ended up having to give parenteral iron every few months. So, and that is, it can be a really tough situation. Has your child or young adult been tested to see if there's blood in the stool?
We have, and we've done an endoscopy, and we've also done a colonoscopy, and so far they aren't finding a source for the loss of iron.
Really? Huh.
Mm-hmm.
But it sounds like repleting the iron and maybe IV so that we're preventing the constipation problem.
Right.
It could be
Right.
potentially very beneficial.
Yeah.
But I think your question was also who should be managing that? Like, it sounds like nobody's really managing this holistic issue that may be involving multiple systems.
Yeah. And that is another situation where kind of on top of all that, like a med check would be helpful. Some of the medicines we use, especially the benzos like Klonopin, they can decrease tone in the GI system and make reflux harder to treat. They can also decrease tone in your airway, and you can get a little bit of apnea that way. So really, even though they're like it's good for so many things, those are some of the potential side effects. So also kind of looking at what meds, if the meds are adding aren't helping enough, or there are meds that could be subtracted, and it's not always an easy question, but something else to look at.
I would definitely encourage the IV iron, especially if there's constipation already. We do that frequently. It can be hard to get insurance to cover it, but it is worthwhile to replete the iron and kind of take that out of the picture and then see what there is. But it'd be helpful potentially to go to an ASF clinic where they have multiple clinicians who work together, because that collaborative team, it sounds like, is really needed in terms of thinking about all the different aspects and how to best treat them.
Great.
Hi, we have a 16-year-old boy, and we only have the fish study that it says he has Angelman syndrome, but we don't have what kind of a study do we have to make to know what kind of AS he has?
I'm sorry, I'm not sure I heard the
I
question.
think she
again.
says he has a diagnosis of Angelman syndrome. Oh, come on up to the front, Mike.
Yeah, we're having
Yeah.
trouble hearing back
Sorry.
here, up here.
I think the question was about the type of Angelman syndrome, correct?
Yes, we only know that he has Angelman syndrome because we have the fish study. What kind of study we have to do to make to know what kind of fish he has?
had a fish.
Where Angelman syndrome he has.
So just so I understand, he's had a fish study.
Yes,
And does it show, and it's normal?
he says he has Angelman syndrome, but we don't have it if
Okay.
dilation or what kind of.
Okay. So a lot of time, we'll start with a methylation test to look to see how the genes are turned on chromosome 15. And that will give you a diagnosis of Angelman syndrome. But to figure out the subtype, a lot of times we'll start with something called a chromosomal microarray, which looks for really small missing or extra parts or pieces of chromosome 15. And it can also identify if the two copies of chromosome 15 are closely enough related that it looks like there was just dad's copy of chromosome 15 that was inherited. So that's usually my first test. It's often called CMA, which is short for chromosomal microarray. And then there's additional testing we can do if that's not helpful in terms of figuring out, is it uniparental disomy or is it an ICD, imprinting center defect? So I would start with a CMA.
Okay. And then we have to go to a clinical AS clinic or with.
If you have a clinic nearby, certainly
yeah.
you could
Okay.
schedule an appointment with the nearby clinic. You could also ask his primary care provider to refer you
Okay.
to a geneticist so that
Yeah.
they can more appropriately do genetic counseling.
But
Can you
just
say
to
again
clarify,
whether the fish showed was positive for Angelman syndrome?
Yes.
Okay.
so, and have they done a test to for sure know it's Angelman syndrome then?
No, yes, we do know that
Okay.
it's Angelman syndrome.
So it's not necessary for sure to do additional testing if they've identified it's a deletion. I often still do a CMA because it can tell you how big the missing part is and whether it's a class 1 versus a class 2 deletion. But if the fish is positive, then it's a deletion type of Angelman syndrome.
Okay.
For diagnosis, you don't need that, but often to get into a clinical trial, you need to know the size of deletion.
yeah.
So then
Okay.
sometimes we'll send it when the patient wants to be in a trial.
Okay. Another question. He has been 4 years with no seizures, and he's on Keppra and Bimpat, Islatravir, and we don't know when to stop the medication. That his doctor asked for an EEG, but it's very difficult to make because he moves a lot, and we don't know when to stop the medication for seizures.
How old is your child?
16.
16. And he hasn't had a seizure in 4 years.
Yeah.
And you're wondering if you could start thinking about stopping the medication. Okay. Yeah. I mean, I would consider it. Sometimes I feel like the EEG is not always that. It's abnormal because of Angelman syndrome. So it may not be completely helpful. If it shows, electrographic seizures, then you probably wouldn't stop the medication. But if it just shows changes that are typical of Angelman syndrome, then you could try, sometimes we try weaning it and say, well, maybe they're done with seizures and maybe they're not. And if we wean very slowly and then have a seizure recurrence, then we'll put it back.
Yep. Yeah. And then the other big thing is, like what medicines are there? If someone's on medicine that we think is causing side effects, then there's a little more motivation to try to come down because, there's something that's causing problems. If it's a medicine, sometimes we'll, what we try to do is prescribe medicines that can help multiple things. So, like a medication like clobazam, if we start it, sometimes it helps seizures and it helps sleep or it helps anxiety. So if a medicine's treating a couple things, we'll usually just kind of leave it because we know it has other benefits. Whereas on the other end, if there's a medicine that we think is causing some side effects but helping the seizures, there's more motivation to come off that. So it also depends on if the meds are kind of having other good effects or bad effects to kind of point you in one of those directions to keep it or not, if that makes sense. Yeah.
Thank you.
Thank you.
Hi, everybody. Hello, hello. The earlier discussion has prompted a question that hadn't occurred to me. Maybe it's simple, maybe not. My daughter's going to turn 40, and it's never occurred to me to have a quote unquote holistic assessment of her state. And the discussion has made me wonder that has somebody thought about this before? Is there, colostomies over 50 every 5 or 10 years? Is there something that people have thought about regular assessments for adults?
It's a really good question. Regular assessments for adults with Angelman syndrome, particularly in their 40s, 30s, 40s.
Yeah, so we did try to address this a little bit in the standard of care document, kind of thinking about what do we need to be continuing to monitor for adults with Angelman. It is a lot of the same things that we monitor when they're children as well. So the GI symptoms for sure are part of that. A lot of times the seizure activity is decreased. But there's also a lot of concerns that can come up around puberty and menses and non-epileptic myoclonus, and then the issues with mobility. So we do kind of have a list of those aspects, but I really do think that's where the clinics that can see adults play a huge role in making sure that there's that holistic approach. I think there's a huge benefit to it.
I'm going to make a beeline. It ain't been too broke, so it doesn't seem to be a lot to fix. But again, the discussion that I've heard at the conference has given me thought there's something to be gained.
We'd love to see it.
Sometimes we'll see adults and look at the med list and everything else and say, yeah, perfect, like nothing to do. But it's always good to check. But I've definitely seen. I even think of one woman in her 30s that was just, she had like really nothing going on, and we're like, okay, you're just come back in a year or two. So sometimes you have that check and it's just like, yeah, it's great. Don't touch anything. But for some people, they are on extra meds they don't need.
And the other benefit to the community, I think too, is getting more experience with adults with Angelman and understanding what the natural history of Angelman syndrome looks like as individuals get older.
As she's on 0.5 micrograms or milligrams of Risperdal and 1,000 milligrams of Depakote. And that's been it for more than 25 years. So
yeah,
I think that was mentioned too about using certain kinds of drugs. So thanks.
Yeah, thank you.
What Hal's question raised an issue for me that I thought would be worth discussing. One phenomenon that I have seen in the last few years is a not sufficient but present interest in adults with developmental disabilities. So, for example, in San Diego, there was a person who trained with us in medicine and pediatrics who saw adults and children as part of her training. And she has tried to establish a practice for focusing on adults with developmental disability. And finally, she was able to do that. Her practice certainly takes some insurances and not others. But when I can, I try to refer adults to go on to see her because she's very knowledgeable about a lot of these issues, not only with Angelman syndrome, but other disorders. And there's also in the past couple of years, a movement within the American Academy of Neurology to have a sort of section devoted to adults with developmental disabilities. And I think there's more and more trainees that seem to think that might be something worth doing. And I try to encourage that with the adult neuroresidents who rotate with us. And it does take hold with some of them. And I don't know if you guys see that in your institutions.
Well, I'll say
Yeah.
across the country at UNC, we're seeing more and more adults with Angelman syndrome. And that has led us to find a network of providers within North Carolina who are within kind of the UNC academic system, who are med-peds trained, who have an interest in caring for adults with developmental disabilities. And I think that that's an important role for the clinic network to be able to support those local providers to think holistically about adults with Angelman syndrome. Anything else from you guys? Right.
to kind of piggyback off of the last gentleman's question. So my daughter is 19. She was seizure free for many years. So her neurologist weaned her off of her Depakote. We saw a drastic behavioral issue. Her primary care then consulted some colleagues, put her back on the Depakote at a lower dose just for the mood, which cleared up pretty drastically. So thinking about now at 19, we're about 12 years seizure free. I'd like to maybe think about taking off of the Depakote. Just, we're doing checking the levels every, like 6 months. So maybe looking at seeing somebody about getting on a medication to really help with the mood, as opposed to, we're not having any seizures. We recently moved to another state, so we established with new providers. And what I'm finding difficult is the neurologist is saying, no, she's not having seizures. That's fantastic. We don't need to see her anymore. Go to her primary for the Depakote if she's willing to do that, which her primary is. But now, I don't know how to then say, okay, what do we do about maybe looking at weaning off of the Depakote and maybe adding a medication just for the mood? Would the primary be able to do that, or would you recommend bringing in another specialty?
That's a great question. It depends on how comfortable the primary is with those things, but what we would do in our clinic was have them see the psychiatrist that works with us, who talked this morning, Dr. Curie. But Depakote's one of those medicines in Angelman syndrome where it's really good for seizures. Kind of like I was mentioning earlier with Clobazam, it can do dual things. It's a seizure medicine and a mood stabilizer. But we also see side effects at bigger doses. Often we'll see kind of motor regression, or in severe cases, we've had kids that just kind of stopped walking on it. So it's always that kind of balance. We have a couple of adults who are on low dose Depakote now for mood because it was really the only thing that worked. But we've had several others that same exact thing. You come off it, the mood changes. So we just replace that with another medicine that can stabilize mood, but that doesn't have all the side effects and the blood draws. So that's, I think what you're thinking is exactly what we would have done.
And you found some success in changing maybe to...
Right.
Okay.
Yep.
Thank you.
Yep. Yeah. Everyone's a little bit different, but we've had, like I said, we've had some kids that kind of had to go back to the Depakote because that was what really helped. But others that did fine on newer medicine.
And if your primary, go ahead.
Just another thing I would emphasize is if you've been on a medicine for many, many years, just really slow cutting it back, because sometimes what happens is you get an effect of cutting it down. That's a transient effect. It's just kind of like the brain adapting to the lower dose. And then if you wait that out, then everything will kind of normalize. So we usually wean those medications very slowly and gradually, and there's no rush to get off of it. And sometimes that's more successful in terms of weaning it.
And I was going to say, if you get back home and you're talking to your primary care provider about doing this, something that we do often is connect primary care providers to folks in the network to provide that support to be able to say, yeah, this sounds like a great idea. Here's how I would go about this, or here's, I might recommend a psychiatrist to help manage X, Y, or Z, or maybe your primary care provider feels completely comfortable with that. But just to get that extra support from clinicians who know Angelman syndrome, we're always happy to do that. And you can have them email clinics@angelman.org, or you can email and we're happy to connect. Come on up.
So I have a little angel, and we're just learning this system and what's available. And one of the things that I think can be confusing is even with the Angelman clinics, they're different from clinic to clinic. And in some clinics, you may see a dietitian, and others you wouldn't. Maybe one has an OT and one doesn't. And so I'd like to hear your thoughts on what parts of care you absolutely need to see a specialist that understands Angelman syndrome versus other areas where maybe a more general level of knowledge may be sufficient. What areas we should really be advocating or finding more specific or more experienced care for specific Angelman symptoms versus a more generalized provider.
That's a really hard question to answer because I think it depends on the comfort level of your pediatrician or who's providing your care. Because some of the Angelman clinics may not have as many specialists, but they have maybe one or two specialists who feel comfortable with all the symptoms that go along with Angelman syndrome, or have some experience with all of them and have colleagues that they can point you kind of in the right direction or they can get advice from. So I think it really depends on the team that you have. I think the most important thing is making sure that the needs of your child are met in terms of the GI needs, seizures and neurology and sleep, behavior, making sure you kind of have a team. It doesn't matter, I think, who the providers are or how many of them there are. You just need to have a team.
So whatever you can get is a good idea.
Well,
Yeah, and we're happy to, we have created a lot of resources. One of the reasons we've created so many resources within the community is so that, so people don't feel like they have to get to a clinic. So if your providers are willing to kind of reach out and talk with experts in the field, I think that's also really great.
Sure. Yes. Everybody is generally very accessible. It is, I know it's a consistent frustration among families that it feels like clinic to clinic, you might find a different flavor. And we are very transparent about the different flavors that kind of every clinic has, but you should be able to find care for any medical issue that your child is having, whether it's a neurologist or a geneticist that might be providing that GI care because they've been doing this for 20 or 30 years and they're super comfortable with that. They have somebody, they all have somebody that they can call on if it goes outside of the scope of what we typically see in Angelman syndrome. And typically that person will be somebody who's also seen, 10, 20 of the more challenging cases of that particular issue.
Right.
So just because a particular specialist isn't necessarily listed on a clinic site, those providers should still be able to manage what we see commonly and then be able to refer if they needed to. Does that make sense?
Yeah, totally.
I would say it also just depends on the severity of the issues. If kids are really doing great overall, there's less of a need. If they're really struggling with seizures, GI, whatever, then it would be more of a kind of more urgent.
The seizures, GI, and sleep, Dr. Thiebert talks about this a lot, as this kind of like cyclical cycle of, they're all interrelated to one another. And so it turns out that, whoever's counseling on seizures, it turns out to be really good at counseling on sleep and
Right.
constipation and GI and reflux as well, because they're also interrelated and you can't counsel on one without thinking about the other.
Right. I have another question.
Go for it.
In the standard of care, it talks a little bit about with communication. It does say, need in the published paper. So it talks about, yes, AAC. Yes. I'm wondering the connection between speech therapy specific to oral motor skills and swallowing, and if there's a connection to reflux and how that plays into it, because there's not a lot in that document about speech support outside of AAC support.
Yeah, so there's actually in the supplemental material, which is a little bit hard to find, there's a whole table that's everything speech related that includes feeding and other issues as well. So definitely that's a good resource. We also, within that paper, so we mentioned feeding therapy separately, which could be an occupational therapist or could be a speech and language therapist, but who really focuses on some of those issues you mentioned, swallowing, dysphagia and suck swallow reflex and tone around the mouth for feeding issues. So I don't know if that answers your question, but there's a lot of so within our clinic, there's speech and language therapists who do focus on AAC, and then we have very specialized speech and language therapists who do other areas.
Right.
Okay. As well.
Thank you.
All right. With a lull in the questions, which have been great, by the way, keep them coming. I'll use this opportunity to dive deeper into something that we've talked a little bit about today, but that's puberty. What sort of changes and issues do we feel like become more prominent around puberty? Dr. Dewis, I'll kick this off with you.
Well, you could pretty much see any of the symptoms we're talking about get worse around the time of puberty. The things that we generally see a lot of, non-epileptic myoclonus comes to mind as something that we're seeing frequently, but we also see some individuals start having seizures when they're cycling. So we see kids who, when they come in every 4 weeks, they're having seizures and they hadn't had seizures for years. And so definitely thinking about hormonal regulation as a treatment for the seizures is really important. Also for the non-epileptic myoclonus. Lots of behavioral things can come up during puberty too. I think there could be associated with things that we have more trouble identifying, like pain. There can be menstrual pain, for example. And so that's something to kind of think about when you're seeing changes in behavior with cycling hormones. So in our clinic, we are pretty aggressive about thinking about treating. If menses is coming kind of early, thinking about treating to prevent periods or to help mostly to regulate hormones so that we don't have that confounding variable. The other thing we see a lot of, it's more, I think, related to the growth spurt of puberty, is a change in the gait pattern is really common as kids start to develop and when they have their growth spurts. I think because their center of gravity changes. And so we see a lot of kids start walking like closer to the floor with that sort of flex knee gait or crouch pattern. And so that's something also to keep an eye on around puberty as well.
That's definitely kind of what we see with puberty. And the one thing that's, and they just had a really good talk about this at the epilepsy conferences a few years ago. So estrogen is actually can have negative effects on the brain. It's what we call pro-epileptic. Progesterone is the opposite. It has good effects on the brain. It's anti-epileptic. When they're in sync, everything's good. But when you get into these times where you have more estrogen than progesterone, especially when you're having the bleeding, that's when you can get the behaviors, the seizures. Because one of the big questions is, if we started like a birth control pill, is that going to make things worse? But for seizures, it often makes things better. There's always a subset of kids. There's a small percentage that have the opposite effect to anything they try. But for the most part, going on, even if you're going on one of the like a pill to suppress the cycles for behavior, for quality of life, other reasons, the effect it's going to have on seizures is generally positive, because you're kind of taking away those parts of the cycle where the estrogen's much higher than the progesterone, which can kind of trigger the seizures.
Great. Thanks. This segues us actually into the motor issue. So let's take a quick glance over the lifespan, how these motor issues kind of change in Angelman syndrome.
This is something that we're actively doing research on, and I'm not sure we fully understand it. Early on, there's delays in motor development, certainly, and motor coordination is a challenge. Ataxic gait, which is that off-balance gait, oftentimes needing to raise our hands to kind of have that balance. And that's something that we think about when we think about Angelman syndrome. But as individuals get older, what we're seeing is that, particularly around that time of puberty or just before puberty, that there's this, it used to be called spasticity. I will say in our clinic, at least, and my experience has been that there is no spasticity, but there's more flexion contracture. So it may be compensatory for that balance issue that they've had their whole life. And then with the change in how they're growing, that we start to see this in the hips and the knees, that then it really starts to look like they're walking closer to the ground a lot of times, and that their ability to maintain stamina, so maintain, particularly if they're going, if you're going to the zoo, for example, a lot of times needing to be in a adaptive stroller or a a wheelchair to really go long distances. And we think there's a component of pain there that we don't quite understand as well. So we're definitely seeing that there's a change, and it's not all individuals with Angelman. It is across subtypes. We haven't quite identified what it is, but certain subtypes, like we are seeing it prevalently actually in the uniparental disomy and ICD subtypes, but we don't have enough data to say that that's more than the deletion subtypes. So we see it though across the board that there's this change in mobility. And I would say, so there was a paper that came out from the Netherlands that said they saw in about 50% of patients. We see it in a slightly higher number of our patient population that we're seeing. But it's a good majority, but it's not everybody that has it.
Yeah. And, that's, kind of, to kind of go back to that, when kids are young, they have the low tone and they usually need AFOs and other supports. And as they get older, I think it is, like Jessica's saying, less spasticity and more just kind of like the flexion contracture. We see like the calves tighten, the hamstrings tighten, and that's where you get that kind of bent forward gait. And the best thing, that you can do is, just stick with, PTOT, and then just get kids on their feet and moving as much as possible. The more ambulatory they are, the more they walk, the less chance there is of having those contractures.
Yeah, I agree. I mean, I think just getting people back into PT, because our patients that leave the school system don't have any PT. And some of the group homes that people come to me from have PT options, but you just have to like write a prescription and say they need to have PT and stretching every day, and that can help. And the more that there's a disuse thing, and sort of use it or lose it. And if you just are in the chair all the time, then your likelihood of going back to walking starts to become less and less.
I really don't have much to add for that, except I think a lot of this sort of worsened during pandemic isolation and people staying at home and being less active. And we're glad that is, hopefully, we're going to be seeing the last of that. We'll see.
Thanks for listening to the ASF podcast. If you enjoyed this episode and would like to support us, please share it with others, post about it on social media, or leave a rating or review. And please don't forget to subscribe.